thank you all for having me. I'd like to really give a special thanks to the K team. They've done a fantastic job, and Thomas and Nathan, the whole team, Sue, everyone has just been world class. And I'd like to thank all of you for putting this together. As I think we all realize, this is an exciting time in health IT. I'd also like to thank Steve K as well. I share your enthusiasm for the future, and things do look bright, but we have a lot of work. I'd like to start off just by introducing myself. My name is Nathan Solomon. I come from Follow Me, which is a PHR vendor. We started our application back in 2000, and it really was born out of a medical crisis. My brother has hydrocephalus, and he became ill basically in the middle of the night, and went to a rural healthcare facility, a hospital, up in the mountains in the Sierra Nevadas. And it was a very scary time for us because he wasn't able to communicate his entire health history, and with hydrocephalus he had had over 18 brain surgeries, and there were very time-sensitive tests that needed to happen to see what was going to become of this interface with the healthcare system and this problem. So out of that, we kind of developed this PHR, and of course I think we share the dream, as apparently Intel does as well. I think we all share the same dream, which is a fully integrated healthcare system that totally enables and totally utilizes current information technology. And really, if you think about it, we're moving, the healthcare system is moving from the 20th century paper-based system to the 21st century and a paperless electronic-based system. And that is a monumental task. I mean, if you look at this as it's just a technology rollout, it's got to be the largest technology rollout that's ever been even attempted, if you looked at it as a whole, and that, as we do. With that, I think we can talk briefly about the problems. We all know what the problems are. The first speaker, Robert Plickard, mentioned something about the cost in terms of not only dollars but in lives, and I think that's something that we've all had personal experiences with. I've read from the Consumer Affairs that the number of deaths solely due to hospital errors is somewhere in the 200,000 range per year. Just litigating those costs about $6 billion a year. So we're talking about significant costs. And I really liked what Robert Plickard said about the, compared to what? A lot of times we present our solution and we get lots of questions. Well, what about the security? What about the functionality? What about this? What about that? And I often find myself saying, well, what are we comparing this to? Yes, we are proposing a system where the personal health record is controlled and owned by the patient. A lot of doctors don't like hearing that. That scares them. They get concerned about being the record being overwritten by the patient, and of course we wouldn't allow that in our system. But this is a sort of thing that we're dealing with. This is partly just a perception. And I'll go into more of that later. Continuing on with the problems, we have incorrect and incomplete medical histories. Right now, we rely on patients entirely for all medical history information. If we have a patient who goes to the same facility over and over again, the same hospital, same doctor, then great, we're going to have a pretty good record. But I don't know about you. In my family, we've had now 3 pediatricians, and I have a 2.5-year-old. We've moved around quite a bit. My wife has had several different doctors. Our health histories are, if we didn't have a PHR, would have been spread across probably at least a dozen medical professionals, offices, hospitals. And this is a problem when you're talking about a paper-based system. It's just not flexible enough, given how flexible our lives all are now. Obviously, there are medical errors, and I went into that a little bit. There are also billing errors. So this is something that we're going to increasingly see patients be more concerned with. And I'll go into more of that later, but really we're part of the system right now, part of the healthcare system, the payers and the employers are shifting a lot of costs to patients. And when that happens, it behooves all of us patients to keep a close eye on what we're being billed for and what all those hospital codes mean, all those billing codes mean. And really, to do that, we need a centralized location for all of our health histories, for all of our billing, and all the medical information. And again, payer shifting responsibility and cost to patients, as this increases, and it's increasing relatively quickly. Now, we're seeing already employers who are shifting to a fixed benefit for their employees, meaning they give them a couple $100s a month and say, go out and find your own healthcare coverage. Good luck. It's typically small business. It's not like an Intel, not a major corporation. But again, a lot of people are covered through small businesses, and this is what they're having to do due to the costs. So again, the problem is significant, and I think we're all aware of that. The solution, in our view, are PHRs. We see the PHR as the heart. And it's the heart because it's the closest medical record to the patient. And we see the patient, you can call them a user, you can call them a patient. We tend to refer to them as members in our PHR, and follow me. And really, it allows for several advantages over the current system, certainly. But even over some other electronic record initiatives as well. PHRs allow for centralized storage and quick retrieval, obviously, I think that's clear. It puts more control of health data in patients' hands, and it allows them to access and see their record, which currently is relatively hard for them to do. They have to go to their doctor and say, please give me a record, please give me a printout, and heaven help them if they try and even decipher that. And this next point, I think, is something that is part of the dream, and it's not part of the current reality, but it combines a history from all data sources. And what this assumes is true interoperability. We do not have anything near true interop. And one of the things I'd like to have everyone go away with today is thinking about how they should define interop. Is interop the ability of a patient to go to a hospital and be given an EHR and a PHR the second they walk in the door? Not really. No, I think, to me, PHR is having the patient's ability to walk into any outfit, any medical center or doctor's office, and utilize any combination of PHR and EHR that's out there. That is interop, because that's what we're talking about when we say the patient has choice, and all the systems are all communicating with one another. That's sort of the dream, and we'll realize that dream when we don't hear things like systems integration costs and legacy, and all these terms that you're going to hear when we start talking about trying to outfit the current systems to speak with the past systems, the legacy systems, with the future of the current systems. And the last item as well, controlled and owned by the patient. This has been this has been our mantra since the beginning, and frankly, it's not been until recently where we felt anyone actually agreed with us. We've had a lot of pushback from medical centers and doctors and providers about patient data being owned and controlled by the patient. And of course, you have to set limits. In our system, we have a provider portal, so the provider can log in and update the PHR, and that information is not editable by the patient, but they can see it. Now, above and beyond that, the patient also controls which providers can have access to the record and which parts of their record they can see. Do you really need the neurosurgeon to be looking at your, OB-GYN records? Probably not. Probably not. So again, we believe that it makes a lot of sense to have the patient control a lot of this. And again, I think as the industry moves along, I believe that will be the future.